Welcome everybody, and thanks for joining us this evening. So we're here to have an interactive discussion on adaptive training solutions in robotic surgery. I really encourage you to use the question and answer feature, and please feel free to ask questions as we go along. The aim is that it'll be a relaxed, informal discussion. I'm Helen Mohan. I'm the Director of Clinical Research here at the International Medical Robotics Academy in Melbourne and a colorectal surgeon at Peter MacCallum Cancer Centre in Melbourne. On the panel today, we have a really great range of speakers. So we've got John Lund, he's the outgoing chair of JCST in the UK, which oversees surgical training in the UK and Ireland, and a colorectal surgeon himself. We have Ben Chalicombe, who's one of the pioneers of robotic surgery in the UK, and who's also recently been running some robotic training courses for multi-platform training as a collaboration with IMRA Guys and St. Thomas's. We have Dan Costello, who's a urology trainee towards the middle to end of his training here in Australia, and he's done a master's in surgical education and has a keen interest in robotics. We have Dave Homewood, who's very early on his training journey in urology as a urology trainee, who's going to give a perspective from the trainee perspective. And we have Christina Fleming, who's the lead for general surgery robotic training in Ireland, and a colorectal robotic surgeon in Limerick. So I might kick off with Christina, who's going to give us a bit of an insight into what the landscape is of the kind of appetite and the need for robotic training.
Thank you, Helen, and thank you for inviting me to participate in this webinar this morning. I think it's a really important topic, and I think, training in robotic surgery, particularly for surgical trainees, is becoming an even more important topic because as we're increasing the volume of robotic surgery we're delivering in our clinical practice, that's leading to a parallel decrease in training opportunities in laparoscopic and open surgery. And certainly if our trainees are not prepared to avail of robotic surgery opportunities, then we're really failing at training. So I think this is a really important topic and really happy to shine a light on it this morning with our other panelists. Prior to becoming a consultant, I was quite active with the Association of Surgeons in Training. And during that time, we developed a robotics working group early in 2021. And really, I guess this was because we were recognizing, how disruptive robotic surgery was becoming and how commonplace it was integrating into surgical practice at really rapid pace. I think at the time around 2019, about 86% of prostatectomies performed in the UK were performed robotically. And annually, there was a 20% increase in bowel cancer resections performed robotically. So the opinion from trainees at the time was, I think close to 90% of them reported that they saw robotics as really important to their future specialty, and 80% of them felt it should be implemented into their surgical training in some way. But I guess in parallel to that, less than 25% had any form of access to robotic surgery training or simulation or any form of exposure in their previous 4 surgical rotations. So it's created quite a disconnect as to what the need was observed at and then what was actually being delivered in practice. So I think that's the landscape. That data is now close to 4 years old. So I think we're seeing an even increasing problem arising from the point of view of, how do we prepare trainees for availing of opportunities in robotic surgery training in practical terms in their rotations. And hopefully that's what we're kind of going to, I guess, figure out by the end of the webinar today.
Great, Christina. I might bring Dave in at that point. As an early year trainee, how have you felt the impact of robotics in your training, and where do you see, robotic training fitting into your training journey?
So I suppose from my perspective, I've spent a lot of time assisting robotically, which is a great opportunity to understand the steps of robotic operation. And I think that's probably consistent with the general experience of people at my stage. I think I've been really lucky to have some exposure at IMRA to simulation and simulated hydrogel models. So I probably had more hands-on console time doing that side of things than other people at my stage. But I think the general experience is people would really love to have more operative console time. And I suppose it's fitting in the best, safest way to do that as part of their training. And probably at a junior level, there's more scope for assisting robotically than anything else.
Great. And John, have you noticed anything in terms of access to laparoscopic training and that kind of balance between laparoscopic and robotic training with the advent of robotic surgery?
Yeah, so in the UK, certainly surgical training's in crisis after COVID. Haven't recovered from COVID, are a long way behind, and we have all kinds of other pressures to do with waiting list, a big political imperative to address that, and a movement of cases away from base hospitals to hubs and private providers. And of course, that's less so for robotics, but the challenge we do have in access is the consultant learning curve. So there are lots and lots of my colleagues who want to be robotically trained and take a long time doing that, and that excludes trainees from that. We've had a look at the number of cases which involve trainees on a robot, and it's only about 800 cases across all of the UK and Ireland per month, so that's 1.75% of all the general surgical cases, and about 3% of the urology cases, even where it's much more established. So there's a huge challenge for that, and it's quite similar actually to when I was sort of coming to the end of training myself and starting being a consultant with laparoscopic surgery, and exactly the same thing was happened there. And of course, what eventually got us over the hump was just training a critical mass of consultants more quickly, and LAPCO was very helpful in that. And I think that we need to do something to get consultants off, or have some sort of gated access to training. You know, people who are at my stage in their careers probably shouldn't be training on the robot. It seems to be a bit of a waste, and we should use that training opportunity for somebody who's going to be providing that service through that technique a lot longer. Because it was obviously a lot easier to train laparoscopically. The kit's much more available. You just wheel a stack into theatre and have the instruments, whereas robot obviously has a lot more limitations and access and geographical thing. And one of the other challenges that we've faced in the UK is about ubiquity of access, and there have been real sort of geographical hotspots and cold spots for where robots are. This seeing the latest data seems to be smoothing out quite rapidly across the UK, which might, the more robots that are available, then the more opportunities there will be for trainees. But certainly, we have overall about over 460 trainees who have their training extended for some reason. A lot of this is about access to training and index procedures. And the robot is certainly having effect on that, because there are fewer cases going through, because as consultants are going through their learning curve, it's taking them all day to do one case rather than fitting two cases on. So the volume is decreasing, and also trainees' access, apart from just being at the bedside, is also limited as well. So there's a big impact of robotic training at the moment. It's going to have an impact on trainees reaching CCT, and also unskilled in robotic techniques. And the other thing is that, it hasn't, Helen and Christina, you've both done fellowships in robotics. And I'm really trying to discourage that, because, there's not an equality of access to fellowships. Not everybody's able to travel across the world, or to go to the centre, or to take extra time to do robotics. Because in people's mid-30s, when these things often are, there's lots of caring responsibilities. And also in the UK, it has an effect on your salary, that you always start on the first point of the salary scale. And so your colleagues in anaesthesia or healthcare, the elderly, have been 5 or 6 years on that, and at least 10 grand ahead of you on the salary scale. And in the UK as well, and sorry to everyone who's watching from other countries, we have a career average pension now, and so it has incredibly long-term effects that affects your eventual pension. So we really need to embed it earlier on in the curriculum, or early on in training. Whether or not, we'll probably talk about how to get it into a curriculum later, I guess. But yeah, so the advent of robotics and the consultant pressure to train is having a massive impact on trainees at the moment.
That's really interesting, John. And I think your thoughts on starting early very much echoes the thoughts here. The RAC's working party group last year, one of the recommendations was that it starts in CEST training, which is the equivalent of SBR training in the UK, rather than waiting until fellowship level. So we've identified some of the key challenges in robotic training, mainly around access and around that multi-level learners. So I might bring in Dan to give us some thoughts on potential solutions, and then I'll go to Ben to give us some insights from integrating it into kind of a real world clinical robotic practice. Dan.
John, I very much agree with you. I'm at the more advanced stages of my training, and I'm tackling the training consultant trying to teach robotics, and it's pretty haphazard. And we're entering a bit of a two-speed race, because I know that RACs have said introducing early set training or when they're beginning, but our philosophy is to introduce robotics even earlier, and we launched a subject at the University of Melbourne this year called Robotics Discovery, and it was oversubscribed, and we've had 5 times the students sign up for our courses next year. So we're now entering a phase where medical students will have more familiarity with the robotic technology than some of the consultants they're going to be working with when they arrive, as interns. So that does create a bit of an issue in their willingness to, or their eagerness to access robotics, because they will have already done simulation, they'll understand the technology, and they'll be keen to get hands-on. Now, in the older era where we were doing mostly open, they'd be suturing and they'd be practicing basic techniques with open surgery. So it's an interesting dilemma we have. The access to simulation has been troublesome because the simulators are expensive, and it's been very much dependent on the hospital that you're placed at on whether you have access to virtual reality simulators. And some of the hospitals did have access to virtual reality simulators, which were on mostly the Da Vinci robot, but that robot was being used for live human operating. So it's in use, around the clock, and pretty hard for the trainees to get on, mostly after hours and sometimes on weekends, balancing their other clinical duties. We're hopeful that we'll see emergence of cheaper simulator options, and I think that's entering the market. We've been working for a number of years in developing synthetic organ models, which are readily transportable, so that we can deliver training into the hospital where the registrars are training, or the residents are training. I think that's a viable option and something we've been working towards. But I think, I agree that challenge is we have experience at various levels. Some registrars are now more experienced in robotics than their consultants, and so what hope does the registrar have from learning from someone who's even more of a novice than them? So, and the other issue I've experienced is that even if the trainee has done a lot of simulator work, are we adapting to that trainee? So it needs to be recognized by the consultant to be useful. So if we're, for example, doing a prostate and you want to do the anastomosis, you've done all the virtual reality anastomosis modules, can you then say to the consultant, I've passed all of these modules to proficiency, can I now do that step? And I think working groups like this have an opportunity to modularize operations and then encourage recognition of prior simulation learning.
I think Ben is in a great position to talk about, as a consultant robotic trainer, how he takes it from the sim lab into the into the bedside, with kind of component operating, and how he gets people on the robot. Ben, you're in a unique situation at Guy's in that you have access to is it 8 platforms? So you have a huge amount of robotic access. Can you give us a bit of an insight from how you've managed to train in that context?
Thanks, Helen. It's obviously we're in a unique situation where we have 8 robots across 7 specialties, and we've had robotics here since 2004, end of 2003. So hopefully we're quite a lot of that 3%, because a trainee would be involved in every case we do. But I'm hearing a lot of things that I completely agree with, about if you're good enough, you're old enough. firmly. If you look at the American model, they're bringing in their robotic training from residency, as far as I can see, sort of day one. I would disagree a little bit with the need for fellowships. I think people, if they want to be expert, skilled, brilliant surgeons, dedicating yourself to a period of intense training to get very good at an operation, I think is going to help you with that, with plus a unique experience. Anyway, I'm biased because I went to Australia and it was wonderful, as you know. But what we've been doing is trying to bring that that bulge earlier by offering some what I think you may have coined, actually, Helen, the Robo Start. You called it Robo Set. We're now calling it Robo Start in the UK, which is a multi-platform sort of robot agnostic course. And I would see this as being akin to a basic surgical skills or an ATLS type course that is almost mandatory for core trainees in surgery, where they are able to, over a 1 or 2 day period, get accreditation for all the basic things you need to do in robotics. They understand about how the machines work, how to dock, how to assist. They can do some dry lab and some wet lab simulation. And they come away with a very early sort of certificate, in terms of what Dan was saying there, where they can come into a theatre and say to somebody, I've got my RoboStart certificate. I could be of use to you. You know, can I help? Can I assist? And that sort of gets you on the way. But my wife, as you may know, Helen, is the TPD for general surgery in South London. And the worst place to go to if you're a trainee in England at the moment is a unit that has just bought a robot if you're a colorectal trainee, because so we really have to try and help that group of people to get trained. And hopefully by running these multi-specialty courses, and then by also running, we have disease-specific courses on gynae or thoracics, we're doing prostate and kidney, we can then sort of skill up people earlier. But I think it's going to be a process. There's no quick fit for this.
Absolutely. And Christina, you've been involved recently when we ran RoboSet at RCSI in Dublin. Do you want to comment on that?
Yeah, so obviously there was 3 days of course delivery in RCSI towards the end of September. Really impressive. I mean, getting all of the important industry stakeholders to buy in, and actually, because whilst, you know, it's very important that training governance, you know, is maintained within the Royal Colleges and the appropriate pathways, we do have to accept that industry are very important for facilitating training across robotic surgical platforms. And I think having that kind of amalgamation of important stakeholders and that relationship has been very important. And I guess, you know, echoing what Ben just outlined, you know, our core surgical trainee working in our unit attended the course. And, you know, since, you know, then we've maybe had 3 or 4 robotic lists, and you can actually see the difference in real terms as well, from the point of view of their confidence with regards to docking, you know, taking control of the first assist position, and actually improving on their own surgical skill as well. And I think that's the whole point of what we're trying to achieve. It's how do we prepare trainees to avail of those opportunities in real terms in the clinical setting.
Yeah, and I think one of the interesting things about robotics is that we actually have more opportunities for simulation, because in some ways the simulation is much more advanced than in laparoscopic, especially the kind of that combination of virtual reality and then the hydrogels. There's a question on the chat there. Compared to lap training, which can achieve even by a homemade lap trainer box and cheap instruments, is there any alternative of robotic training? Dan, do you want to come in there, maybe about kind of the hydrogel models and getting training a bit closer to home?
Yeah, I mean, we worked a number of years ago with a surgeon who's now at Johns Hopkins, Ahmed Ghazi, who was a real pioneer in fabricating hydrogel models. And we were a good test case because it was during COVID, and the initial plan was for him to fly over and do hands-on training on how to use these models. And obviously the world closed for a period of time, and instead we had to vacuum seal like you would a fine cut of steak and send it in the post. And then we did a virtual meeting about how to set up the simulation, and we're actually demonstrated just by that experience that you can actually vacuum pack these small, very realistic synthetic models and post them to anywhere around the world. So that's what we've been working towards, because the other thing that we realized is we have a very specialized lab in Melbourne with all the technology and multiple robotic platforms. But surgeons and trainees are so time poor that they can't come to the lab at any opportunity at all opportunities they have. So we're best delivering the training to them in their hospital, and then having intense periods like RoboStart or dedicated courses where it's a weekend intensive, but there's consistent home-based training. And so we've overcome a lot of those barriers with super realistic transportable models that we can put in the post and send to the trainee, with an online module that you can watch and learn how to do the operative steps with independence and access the robot when you need. So that's one way we've overcome the hands-on element anyway.
Yeah, and Christina, you've run a training course, the Right Hemi course, locally in your hospital. I
Yeah.
guess we're not a home simulation, but at least that brought it closer to home.
Yeah, exactly. And I think the whole point of the models being dry models as well. So the whole, setting within which they can be utilized in real terms, I think is very adaptable. And certainly from the point of view of colorectal surgery and the, basic and more complex skills required, they're very high fidelity for actually what is required. And also like we're at the other side of the world, but that was no issue from the point of view of being able to deliver on them as well. So, I think that point that Dan makes is important.
I think another important thing that John raised was that balancing of competing training interests and where we fit things in. John, any thoughts on how you kind of would integrate robotic training in a UK context with your competing interests?
Yeah, so I mean, we do have a bottleneck, and that's going to be eased over time as the number of robots available around the country get better. But I think it's sort of industry. I know we are going to expand that lab-based training very shortly, like in the next couple of weeks, and so that'll be much more available. And depending on the platform, I think the other opportunity is to load some of the robots into a van and then have regional teaching that arrives near you for that basic course that Ben and everybody else has been talking about. So I think that things are going to get a lot better. Capacity is has increased, and then so in terms of like the moving through, I think that we need to prepare the ground. So people in early especially training, so ST3, ST4, or perhaps even core, need to do that stuff in the lab to get them up to speed, particularly with the all the things that we talked about. And I think the other thing that'd be really helpful would to be develop a training the trainers robot specific course, and what that would do would make it easier for trainers to train in the robot technique, to make them consciously competent of what they're doing, and then allow them to feel sort of much more comfortable in giving over the reins to somebody else to accelerate that process of passing those skills on without the need for a proctor arriving to do it as we train in any other thing at all. And then on the multi-platform thing, Ben's in a fantastic and unique position in having so many platforms available. But we do have to make this agnostic, particularly for support from any curriculum and also from the statutory education bodies in the UK. So, it's about going to a hospital, training on whatever platforms in a hospital, but we don't want people to be tied into that platform, which would limit the scope of consultant jobs they got. They have to go to, a Da Vinci hospital or a CMR hospital or whatever platform you've got hospital. So we do also need to develop proper transfer courses for those at the end of training, which might not take very long. Some platforms are very similar, some are quite a lot different, and so it'll need a bit more. But just to have a transfer course at the end for people who are competent on one platform, so that they can demonstrate that they're safe on the new platform to allow them to do any job like, and have some sort of one-day driving license for that. And I think if we bring those three things together, then that will happen. The main thing is about capacity, and that is something that's probably going to just take a little bit of time, and we might be stuck where we are. We can facilitate things on the outside with simulation, etc., as much as possible, but there is no actual substitute for operating on real patients in the real world.
Absolutely. And I think I would echo what you said about the train the trainer. One of our master's students has developed a train the trainer course with us at the moment, because her thesis is focusing on expanding equity of access and really training the trainers we identified as one of the key needs in expanding equity of access. Ben, as somebody working in a multi-platform environment, how have you managed to integrate training across different platforms for your urology trainees?
Yeah, no, that's I good points. Again, I'm learning more, probably more than from everyone that may be learning from me. Is often the case. So I'm here. I'm a bit ad hoc at the moment because I'm at St Thomas's, and the reason for that is that we're starting within a second case with a CMR robot in paediatrics, and that's why I'm not in any sort of office, and I'm on the way to go and help them. So I'm constantly thinking about, when we start a program, how not just we're going to train the consultants, but how we're going to train the residents, as we would now call them, in along that way. What I would say, a few points is, one is it's very possible to move between platforms. You do, as John says, you do need a teaching and training on the new platform, and you do need to do simulation on it. But this week I'm clinically operating on live patients on 4 different types of robot: SP robot, Da Vinci Xi, CMR, and Hugo, doing complicated stuff. And that takes me 5 minutes of just getting my head around the console, and you can change. So we will switch on a Friday where I do a Medtronic list and a Da Vinci list in parallel. We would have trainees moving back and forth amongst those. And the trainees that are listening need to remember, you're good at learning stuff, guys. Yeah, you're young people. Young people learn much quicker than old people, and you're much more adaptive. And I put you on a simulator in an hour, you'll be able to beat me at pretty much any exercise. And that's from 3,000 cases. You can still do it because people learn very quickly. So I think we can be very enthusiastic about the fact that, given the opportunity, trainees can move across platforms. It is still difficult, and the trainers need to have a mindset of training. Now, I'm in, one of the oldest teaching hospitals in the world in St Thomas's and Guy's, and therefore most people here do have a mindset of training. But with that train the trainers, you also, I think, need to have the trainees thinking about, how do I broach that conversation? It's the same whether you're doing an endoscopic open or lateral case as well, about how am I going to get the maximum amount of benefit out of this next case that I can get. And I coach people about that. You buy someone a coffee, that might help. When you're scrubbing, you tell them, like Dan says, I've done the anastomosis 6 times. I don't really interested in dropping the bladder. Could I do a bit of the anastomosis today? And you try and just sort of nurture people along with that relationship you have with the trainer to try and maximize your opportunities at each operation you go to.
I think that's a really important point. And I benefited a lot in my fellowship from working with Satish Warrior, who is a colorectal surgeon here in Melbourne, who's very intentional about operating steps. So he'd start a conversation at the start of a case to say, which steps, who is going to focus on what step today. And I think that kind of breaking it down into component operating and identifying which steps. So at the moment, we usually get the new fellow doing some of the easier steps, and the kind of we've 2 fellows, our more senior fellow does some more advanced components. Christina, from kind of the real life scenario and bringing it into real life, any tips and tricks or thoughts on kind of bringing it into the bedside?
So I think I obviously trained in that parallel component model as well on fellowship with Quentin Denost in France. And, he has actually published data to demonstrate, that even with 3 people at a different stage of training and performing, stage appropriate parts of the procedure, that everyone achieves a significant improvement in their gears score. So it's very effective from a training point of view, but also from the point of view of patient outcomes. There was no compromise, and operative duration as well compared to consultant-led operating, there was no significant difference. So I think that's a very safe model, and it's the model that I found very successful to learn in, and it's now the model I use to teach. And I think that overcomes one of the barriers with regards to practical implementation around consultant learning curves. Because, mobilizing the colon, for example, in an anterior section is going to be, a lower complexity element of the procedure that as a consultant, you probably master pretty quickly. And then that's a training opportunity you pass on. And having those very clear training timeouts, like you described, Helen, at the start of, the operating list, I think to focus everyone's mind on that is really important. I think the other two areas with regards to practical implementation that need consideration is training governance and overall trainee preparedness for entering, an environment that has a robotic surgical platform. So obviously a lot of the training, and this is changing and very positively, but a lot of the initial training when I was a trainee was exclusively industry delivered. And there wasn't a model for the trainee within that was consultant focused. So it's been very welcome to see the Royal Colleges, the JCST, all starting to understand where the governance of this should lie with regards to integrating trainees into robotic training. And then with regards to preparedness, I think it's very important that as trainees, we understand and that, performing robotic surgery isn't just about sitting at the console. It's really, utilizing a very complex surgical technology in a very complex clinical environment. And I think there's huge opportunity for preparation prior to that. So from the point of view of e-learning, simulation, device training, these are all things that we can deliver outside of the operating list to ensure that the trainees are prepared. And working with IMRA and other industry leaders to facilitate this, I think is very important as trainers.
Great. And I think in terms of that kind of broader aspect, one thing that we've kind of been quite keen on at IMRA is kind of multimodal training and having a combination of technical but also non-technical and human factors skills. Dave, do you want to touch on briefly the Delphi that we did recently and just like the key points from the Delphi?
Yeah, of course. So the Delphi consensus aimed to establish core components for robotic training globally. There was an international committee that reviewed literature and collected input from surgeons, trainees, and training providers. The consensus was reached on 139 statements across 15 themes, and the key recommendations included that, as we've already mentioned, there needs to be a multi-platform curricula that's technology agnostic. It needs to include non-technical skills. That there needs to be relevant clinical performance metrics, and we need to shift from cadaveric to synthetic models.
Dan, do you want to talk a little bit about the kind of human factors aspects and the non-technical aspects of training, and kind of your experience with kind of training on that in the sim lab and then going into real life and kind of transitioning that into theatre as a trainee?
Yes, COVID wasn't all bad. There were some good things to come of it. And one was the standing down of Captain Matt Gray, who was Chief Training and Testing Pilot Qantas for 25 years. But because of COVID, he wasn't flying anywhere. So he came and worked with us at the Robotics Academy in Melbourne and helped develop our human factors training based on how they train airline and fighter pilots. It was very interesting because the airline industry is a long way ahead, or they were until now, a long way ahead in the use of virtual reality simulation and high fidelity simulation. And there was a lot that we learnt from how they train their pilots, who also work in pressurized scenarios. It's very different operating, as we know, compared to flying a plane, but a lot of the pressures are the same. And it was interesting to talk with him over a couple of years as we developed these courses about cognitive overload and putting various operating room scenarios onto trainees and how they would respond. And there was one scenario that in particular he talked about called the startle effect. And the startle effect is when, for example, the pilot's taking off and they have a bird strike hitting an engine and they're in a simulator, suddenly an engine goes out and the light starts flashing and they say, how do you manage this? And then they would attempt the simulation, then debrief, and then they'd try again. And as you become more familiar with these, disaster scenarios, your startle effect reduces and you can actually maintain a higher level of cognition and make good decisions. And and behave at a higher level. Now, in the operating room, we worked on a simulation where we would essentially replicate a bleed. So the trainee would be cutting in. We were doing this in urology in a partial nephrectomy. They would hit a vessel, and then you can squeeze the vessel, and it sprays, onto the camera, and then you assess their response. Now, it was very similar to what the pilots experienced in their startle effect. And an important part of that was actually having a positive training experience where you would debrief appropriately with the trainee. So it wasn't just having a high fidelity simulator. It was about using this as a training opportunity. Now, I know that the generation ahead of us probably went through the operating room scenarios where there's a bleeder and the consultant hits you on the back of the hands with the back of the scalpel or yells at you, and it's not necessarily a positive training experience. It's a startle effect and a negative training experience, which isn't as useful. But with simulation, we can actually use great trainers that we can teach about how to debrief with trainees, how we can learn from pilots and how they teach in these scenarios and incorporate that into live operating. So we've developed a course which has different live scenarios that the trainees go through, and then we have a debriefing session. And I think that's something that, John, you mentioned in the train the trainer, that is really helpful, and that's what we'll be hoping to work towards.
There's a couple of questions on the chat, so we might go to some of the questions. Somebody has said, where's the best place to go for a lab-based course for a beginner? I think that very much depends on where you are and what the access is. If you're in the UK, I'd suggest going to Ben at Guy's in St. Thomas and doing RoboStart.
You've been flying all around the world, Helen, so you're doing these courses, so you could probably talk from your first-hand experience in the past month.
Yeah. And then Ronan O'Connell has asked, how do you overcome limited use of instruments when training on the hydrogel model? And I guess that again, to highlight Christina's point, is the importance of being able to use all the available robotic platforms. So I guess the advantage of the hydrogel model is that we can use it in a local theatre setting using training instruments. And being able to kind of utilize all the available robotic platforms that are already there as we try and expand access to training robots. And then also that important link with industry partners and getting industry partners to bring robots to courses and to simulation days. Anything you want to bring in there, Ben? You've had a very a successful track record in getting multiple platforms involved and getting a lot of support in that setting.
Thank you. Yeah, I mean, I think you make the key point there, which is that everybody's robot is a training robot if you're using models. If you have cadaveric labs and pig labs, firstly, you can't really use those instruments on humans or sometimes the actual robots. You've got to move, it's expensive. So if we have cost-effective biodegradable models, you can put those on the operating table once the patient's off on the evening after the list, and you can train. So we on the negative side, though, Helen, it's very difficult for me to be sustainable with this because it obviously costs quite a lot of money each time we run a course. And I am envious of the IMRA setup where I think you've got quite a good buy-in from industry, and we need to sort of get over that where the industries don't look at each other, but they all look at the actual outcome of the trainees. And so we're running another RoboStar February 28th next year. I'll put out a thing on that on Twitter. And that will be anyone UK. We've had Ireland and we've had all around Europe coming to these courses to get some hands-on on all the three different currently UK licensed platforms. But I think it is difficult, and there is a group within the UK called Radar, which is a sort of multi-stakeholder group, which is trying to come up with a document that will I think a lot of the things we're talking about will come out of this, that there will be some basic courses and disease specific, procedure specific courses. It'll be multi-platform, platform agnostic, and that there will be centres all around the UK who can offer that. So I think the UK probably needs somewhere in the order of 4 to 6 major training centres regionally to start offering these courses. And then hopefully you can maybe buy a model if you're a trainee, and you can use it several times and use it on your own home robot after the consultants finish the case, or you finish the case.
Christina, obviously RCSI has got a lovely simulation facility and great opportunity to train there as well. Do you want to comment on the kind of RCSI approach?
Yeah, so I think we've been very lucky with the appointment of Professor Barry Maguire as the Professor of Postgraduate Surgical Education and Academic Development the year before last. He's a very experienced robotic urologist, and I think a real champion of robotic surgery. And I think it probably needed someone to champion robotic surgery to really bring what we can deliver to trainees to the next level. We're also quite lucky because I guess the surgical community in Ireland is a small community, and we have a very clear central hub in RCSI where there is, by world standards, a phenomenal simulation centre. And we're very well supported by a full-time simulation team, including Rosemary Cadigan, who's a very experienced robotic first assist, and also a simulation team who work on model development as well to guide our training. So Barry has developed a group of surgical leads. I lead for general surgery, and obviously this is all very specialty specific. And I guess what we're trying to do is firstly support robotic surgeons in their own hospitals with regards to best practice, but then also put a shape on how we deliver robotic surgical training using RCSI as a simulation hub, but also we're currently working on how do we formalize a curriculum. I think two of the biggest barriers to integrating robotic surgery into a curriculum for surgical training is having, enough of a volume of robotic surgical trainers to mandate it and having access to platforms. And I guess because we are that little bit smaller, I think we've probably overcome those two challenges. So we're probably at the right time for this. And I would hope by the next academic year, so 2025, 2026, we'll be able to bring that in more formally to our surgical training delivery. But at the moment, it's quite opportunistic with regards to when we get access to platforms with industry. But we have, had training days with various platforms and very favourable feedback from trainees as well.
And I guess the other thing that we don't overlook, we're mainly focused on soft tissue robotics, but obviously there's a wider robotic kind of landscape out there with neurosurgery and orthopedics. John, have you any thoughts on kind of the wider robotic access as somebody who's kind of overseen all specialties and training?
Yeah, so we've just been looking at pan specialty thing, and each specialty has its own needs. So neurosurgery, for instance, were the first specialty to use robotics back in the 70s, and then have by and large not really touched it since. Vascular surgery, we're thinking about this for aortic and another work, but again have really not really found that niche for robotics within there, and differently across. And so I think urology are obviously in the lead here, that they've been familiar with and had robotics as part of their armamentarium for much longer than other specialties by and large. In general surgery, about second. T&O are coming up very quickly, as there are lots and lots of advantages in terms of functional outcomes in the end with robotics, and I expect to see them come up. But again, it's all the same challenges. It's about supply and demand, and that bottleneck of training the existing consultant workforce versus resource available to provide everything else. But and I think a lot of this comes down to simulation. We've said robotics is interesting, isn't it? Because it's one of the few things in surgery. It's probably quite a lot like aviation simulators, in that there's no, at the moment anyway, no haptic feedback, no tactile feedback for what you do, and so you are just interacting in real life with what you see on the screen. So what we need is probably a slight increase in computing power for the future simulation, so that you just interact with the screen. So you don't need the robot, you don't need real arms, and it's all VR with this, because you get what is essentially exactly the same experience as what you do sitting at a real console in a real theatre with a real patient. just that you're just interacting with the images on the screen. And just also to facilitate training, it is a lot about cognitive load, and as we've been saying earlier, and there's lots of work done by Steve Ewell and his group at Edinburgh and others about cognitive load, and we can measure how much cognitive load is and the things to do to ease this. But one of the things that we can do to ease this quite successfully is to have that briefing beforehand and establishing what people are going to do, both trainees and trainers, and what part of the cases massively decreases cognitive load, and talking about what you're going to do, and coupled with a proper debrief at the end, I think will hugely accelerate training. And also, you know, that coming back to training the trainers in robotics, that will also decrease cognitive load. People will be much more comfortable with training, decrease their cognitive load, and give them the capacity and confidence in real life to be able to train people without their heart racing, and without them wondering what a thumping sound is from their massive blood pressure in their ears. And there is a proper cardiovascular effect on this that we've measured it before with heart rate variability. You can see a huge extra pressure in heart rate variability when people are training, which you can decrease substantially and take stress off with some of those interventions.
Yeah, and that's a really important point. One of our PhD students who's done a lot of work on multi-platform training, Kirsten Larkins, has done some lovely work looking at cognitive load, which will be out shortly. Just coming on to that point that you said about the pressure of training interoperatively. There are also advantages to robotic training compared to laparoscopic that I think we've talked about the challenges, but there's also some differences. So certainly one thing that's nice as a robotic trainer is that you're not in physical pain holding the camera. So you have for the ergonomic aspects, you're actually very comfortable and in a very controlled manner when you're able to teach. Christina, I don't know if you found that, you know, the differences in kind of training laparoscopically versus robotically. I find the physical comfort of robotic a lot easier to train.
I agree, and I suppose to be clear, you know, the system that we use for training is the DaVinci Xi, and we have a dual console. And I think from the point of view of being able to transfer to a training opportunity by the press of a button, as opposed to having to move everything around, change retraction, move the level of the bed, you know, it's a difficult metric to measure, but I do think it increases training opportunity because it's much easier to give the training opportunity, particularly when someone is at the very beginning, being able to maybe personally control the fourth arm, and they can work with 3 arms and have that very kind of graded autonomy to develop clinical skill. You know, and our surgical workforce is very diverse. We're all different heights, we're all different shapes and sizes. So I think from a very practical point of view, and standing around an operating table and the ergonomics associated with that, that there are huge benefits. And even as a surgeon on a personal level, certainly when I was pregnant, I think probably my ability to continue doing resectional work was, you know, prolonged by the fact that, you know, the ergonomics of sitting to a robotic procedure are less severe than standing and doing a laparoscopic procedure. So I think there's a few really positive points about that.
Yeah, I would definitely echo that. As a pregnant consultant last year, I also felt that it prolonged the amount of time that I felt comfortable operating. Ben, in terms of training using kind of open console, you swap in and out. Do you get everybody to wear the glasses at the start of the case? How do you approach that?
Yeah, for people who don't know, the CMR and the Medtronic Hugo both don't have a dual console because you don't need one because it's open. Therefore, anybody watching, as long as they stand within about 20 degrees of the screen, can all kind of huddle round. Yeah, so there's always 2 other sets of glasses. So we've always got a minimum of 2 other people watching at any point. In the Hugo, you've got one set of glasses controls the robot. So you've got to remember that when you switch over to the trainee, they need to take the controller glasses, which have got little metal bits on that are picked up by the eye trackers. But yeah, we did a little paper on some students who came into the ORs having not seen either robot in clinical use, and just said, what do you think? Complete open mind, what do you think about the different systems? And they scored the Open Console Hugo more highly than they did the Da Vinci, because for them it made more sense. I was able to look up, see the anaesthetist, see the assistant, see the scrub nurse, direct line of sight, easier communication. They could hear me, they could see my hand movements when I was demonstrating things. So I think from a training perspective, it's different, but in many ways it's got a lot of advantages, the Open Console.
Yeah, I think like anything, it's about understanding each platform and what its specific advantages are. So you can leverage the advantage of each platform, and I think they all bring something very unique and very special to the operating room. And then just coming on to some of the questions in the chat, there's a comment there about whole team training, and multi-team, kind of the whole surgical team training, which is something that I would completely echo. We've certainly focused on getting a nursing course and an assisting course up and running here, and having kind of the whole team training. John, from a kind of wider surgical team kind of perspective, any thoughts on how that fits in a UK context, and how we train kind of the whole operating team?
Well, it's vital, isn't it? I think it's something we don't pay enough attention to at all. I think because robots that bit more technical, it's probably essential to have a stable team, and then group training. You got to there you are, you're back constantly now, and about that. And I think in such a technological complex thing, when something goes wrong, you don't need somebody who hasn't been there before, which you often get in open surgery. No one has a clue what instrument you need or where it is, and someone said, "Oh, that should be working," and so it's vital to have proper team training. And I guess that probably needs to be supported by industry, and industry have a lot to gain from this. These things aren't cheap, and there are lots and lots of on costs in terms of equipment, etc. So it's a thing that you don't just sell me a clamp and that's done with it for the next 30 years. That this is an ongoing investment, and so it's very much in industry's interest to train teams properly to make robots as effective and safe as possible. And part of that is the team training, something I think underdone certainly in that, and multi-professional learning overall, I think, in those environments. So simulation days, what we've done with laparoscopic training in certainly in my region, some other regions, has had that multi-professional cadaveric laparoscopic training, and robotic training should be the same in a very high fidelity simulation thing, where again you can train for those disasters as a team and those technical failures as a team to do what Danny was saying, is overcome that startle response, so that when something happens, everybody's calm. The last thing you need is anybody panicking in those situations.
Yeah, I definitely would agree. And I think having the nursing component in our kind of curriculum portfolio at IMRA has been really important, especially at hospitals where we're getting a new robot, which I think is a really important component. I think one of the advantages of robotic training is it makes you be more verbal. As you said, John, you don't have as much kind of non-verbal communication. And we know that a lot of surgical communication traditionally is non-verbal. So being more intentional about how we verbalize things can actually have some advantages for training. Christina, have you found that you verbalize a lot more on the robot? Any thoughts on kind of being more intentional with training and verbalizing?
Yeah, and I think coming back to, using like an open versus closed system as well, certainly when you're looking down the tunnel, there's like total loss of body language. So how you actually use your words is very important. But also like understanding that communication dynamic within the team and having consistency in the team members is very important. Because as with most, I would imagine, hospitals across Ireland and the UK, we don't always have significant consistency in the non-medical members of our operating team. So being very clear and concise in and intentional, as you say, with regards to communication is hugely important. And we have held previous like rehearsals with regards to emergency scenarios as well. And I think, you know, understanding the importance of communication comes across a lot more clearly to all members of the team when you rehearse, you know, specifically what can go really wrong if we don't all understand kind of the importance of speaking very clearly. So
Yeah. I think we're kind of coming to the final of 5 minutes, so I might just hand it over to everybody for a quick take-home message. There is one challenge, I think, in the chat, which I think is an interesting question. How do we expand access to kind of, it was somebody who asked about access to in an African context to areas that have underserved in terms of robotic surgery. I think expanding access to minimally invasive surgery and robotics is going to be one of the key kind of global health equity challenges over the next decade. So I might hand that on to John. Any final comments as we wrap up?
No, it's been really interesting, and I think we are moving in a very positive direction. Things are getting better much quicker, and I think we're almost in a position where we can not necessarily embed it explicitly within the curriculum, and there's all sorts of technical things around regulatory approval for that, but certainly have something where training can happen for everybody, no matter where you are in Western countries, at least. But I think that the main thing I come back to, certainly in the UK, is training is in crisis. Consultants need to remember that they were trainees. Somebody trained you if you were a consultant, and so you need to give that back on whatever modality of surgery that you're using, be it open or laparoscopic or robotic or anything else that comes on. You need to train the next generation for the future of surgical healthcare in your country.
Yeah, I do love the hashtag that you use, John. No training today, no surgeons tomorrow. I think it's always very inspirational for us to do better with training. Ben, any final comments?
Yeah, it's we have challenges. I mean, surgery's obviously always had challenges. I generally tend to be an optimist, which is why I come to work each day and take on crazy things and think that it's always going to go fine, and it doesn't always do that. But I totally agree with John's point. I mean, we as trainers need to be much more sort of positive to the trainees to say, what can I teach today? How can I maximize the experience? And for me, you know, a good list is doing high quality surgery that finishes in a good time, but with training involved. And I think, you know, that's and the robotics has got so many advantages for the patients that it's just great to get access to these different systems. I think that we really need to get the younger trainees on the systems. And if I was a trainee right now, the earlier you choose what to do, the easier it is. Because no one can back you if you are getting to ST6 and go, well, I don't really know, I like everything, it's all been really good. Whereas if you're ST3 and you say, look, I really want to do this, then you've got much more chance of progressing. So as much as you can, trainees, choose early, find a mentor, and have that good relationship. But thanks for having me along.
And thanks to all of our speakers for a very informative discussion. And happy to chat further to anybody who's listening if they've any interest in chatting further about robotic surgery offline at any stage, or any of our research or getting involved. Christina, I'll give you the final soundbite as we head into the last minute.
Well, I think I just echo completely what Ben and John have said. As consultants, if we're going to be utilising robotic surgery in our clinical practice, it is very important we ensure that we create training opportunities within that. And I think also we have a real opportunity with robotics now. Robotics has been the biggest disruptor since laparoscopic surgery, really, in our specialty. But newer technologies and newer innovations are going to come into clinical practice a lot quicker. So getting it right with robotic surgery allows us to really create, you know, an adaptable blueprint for future technologies as well. So we are responsible for using this responsibility for our trainees.
I totally agree, and harnessing that benefit for our patients with adaptive training solutions. And thanks to everybody for joining us and for listening in this evening. Take care and good night.